It gives me great pleasure to introduce Dr. Ardie Pack-Mabien. I believe that you're presenting our case today on multi-system hospitals and other things.
Let's see, let's start to share. Make sure this is the right one. It is. Okay, and so I thought it would be quite interesting to do something a little bit different today and looking at sickle cell disease, the crisis beneath sickle cell pain. And so we have a 37-year-old female with homozygous sickle cell anemia that was first seen as a new patient back in 2019, related to multiple and recurrent intermittent simple red blood cell transfusions for severe anemia and iron overload, at which time she was placed on hydroxyurea and JNU. Both were implemented with a desired response. And so initially her ferritin was like 5,551. After chelation therapy, we got her ferritin down to 1,508. Her hemoglobin, when we first saw her in clinic, was 7.8, and that was status post 2-unit simple packed red blood cell transfusion by our PCP at an outside facility. After starting hydroxyurea, we got her hemoglobin up to 9.1. So she came to clinic on March the 23rd for her routine follow-up visit and was subsequently directly admitted to University Hospital. She presented with a complaint of bilateral lower extremity pain that she described as achy. She also had chest pain that was worsened with inspiration, shortness of breath. She had a cough with mild sputum production, febrile illness, and chills. She denied nausea, vomiting, and upper respiratory, urinary tract symptoms. She had been recently discharged from an outside facility near her residency in another county, where she was treated for acute chest and received 2 units of simple packed red blood cells. And then during that hospital admission, she also tested positive with her DAT with an anti-C warm and cold autoantibodies, but was not treated. Up until this time, this was like her second admission for the year of 2023. And we ended up having to readmit her in May as well. Her diagnosis was sickle cell pain. She is seen by the adult sickle cell provider. She does have a primary care physician as well. Her pain that day was rated 10 out of 10, but her baseline was 4 to 5 out of 10, for which she takes Norco 10. She's also on hydroxyurea. Her JNI was on hold pending her audiogram. She's on vitamin D, ibuprofen, and Flonase. Her past medical history is significant for secondary hemochromatosis, multiple antibodies with a history of recurrent autoimmune hemolytic anemia. She had a stroke as a child, but declined chronic transfusion, but elected hydroxyurea, microalbuminuria, vitamin D deficiency, mild cardiomegaly, status post-cholecystectomy, and a history of valvular heart disease. Her audiogram was normal back in 2021, and her eye exam back in January of 2022 was negative for sickle retinopathy. There was no history of depression, anxiety, substance use, bipolar, with no suspicion in terms of misuse of her opioid analgesics. She is the mother of one daughter, age 11, formerly worked at Walmart part-time, lives with her mother on Medicare. She travels 40 miles one way to Mobile. She's a non-smoker. Her urine drug screen is negative for illicit drug use. Now, what's significant here, I thought, was that her aunt, who had sickle cell disease, passed away from complications that included a history of stroke. She was on a chronic Q4-week exchange transfusion regimen, pulmonary hypertension, proteinuria, CKD, recurrent PE, and was on supplemental O2. Her current dose of hydroxyurea was 17.5 mg per kg that was held during her hospital admission, secondary to elevated LFTs. Her ANC at the time of admission was 5,445. In terms of her transfusion history, and I do have Dr. Baruka that's on with us, our team pathology from the blood bank, to address some of her transfusion issues for this conference Zoom. Again, she had a history of red cell alloimmunization antibodies. We do have an active sample in the blood bank, and her last transfusion prior to this clinic visit was February the 28th at an outside facility. Her labs during that clinic visit, her heart rate was 124, and as you can see, her baseline was 80 to 93, so she was indeed tachycardic. Her blood pressure was 123/77. She was afebrile and on room air had an O2 sat of 98%. Looking at her labs, her baseline hemoglobin ranged between 7.1 and 9.1 with a crit of 21 to 26% in the absence of transfusion while on hydroxyurea. During the day of admission, when we saw her in clinic, her hemoglobin had dropped down to 6.2. Her hematocrit had dropped down to 18.2%. Her white blood cell count baseline is 2.5 to 8.7. On the day of admission, it was 4.85. Her MCV looked like she's actually taking her hydroxyurea. Her MCV had gone out to as high as 124. And if you look at her hemoglobin electrophoresis, her HPLC on the day that we actually admitted her, her S level was 73.6. We can see that she had indeed been remotely transfused with an A1 of 17.8%. Her fetal hemoglobin was 5.3 and A2 was 3.3%. Her serum creatinine baseline is 0.62 to 0.65. Her tolerability that day was 5.3 and repeat 5.4. Her alkaline phosph, her baseline was 220. On the day of admission, it had jumped up to 571, a repeat of 578. Her tolerability ranged between 1.2 to 2.0. On the day of admission, it also jumped up to 5.3. Both her ALT and AST were also elevated. And her ferritin, again, we had gotten it down to 1,508, but during the admission jumped up to 6,203. She was actually admitted into the ICU. She was treated with IV Dilaudid, incidence spirometry, DVT prophylaxis with Lovenox, folic acid, Benadryl, PRN, PO, Zofran, Narcan, and we actually started her on prednisone 20 milligrams along with prophylaxis antibiotics. Abdominal ultrasound was also ordered, and because of the elevated LFTs and total billing, her hydroxyurea and J-nu were both held during the admission. We consulted GI for the elevated LFTs and bilirubin. They did the abdominal ultrasound. It came back consistent with hepatomegalia, with a liver measuring 19.6 centimeters, and basically signed off with a diagnosis of elevated LFTs secondary to sickle cell hepatopathy, sickle cell disease, secondary hemochromatosis, and that was it. So for her autoimmune hemolytic anemia, where she tested positive with a DAT, positive for IgG, negative for C3, her transfusion medicine report of multiple antibodies, we consulted hematology and heme pathology combined. She was treated with prednisone that was bumped up to 60 milligrams QAM and PPI prophylaxis. And then she was also transfused 1 unit of least incompatible packed red blood cells on the 26th, the very next day after she was admitted, where her hemoglobin had dropped down to 5.4 and patient was basically hemodynamically unstable, symptomatically anemic. Her O2 requirement had gone up and she was still tachycardic. And then here's her transfusion medicine report. I'm not a hematologist. I'm a family practice nurse practitioner, but Dr. Baruka is on and can address those questions. Again, she did test positive for IgG, negative for C3. The recommendation from hematology, heme pathology was to transfuse her units negative for C, FYA, JSA, V, and VS antigens. Approximately 6% of the ABO RH compatible units should be for this patient. They were also negative for K and sickle cell. Her chest x-ray on the day of admission, findings were consistent with bibasilar atelectasis, but was negative 2 days later. The CTA of her chest was negative for PE, but showed an enlarged right heart, so we got a TEE. that was obtained, and the findings were consistent with pulmonary hypertension, for which cardiology was consulted. A right heart cath was done, and the findings were indeed consistent with pulmonary arterial hypertension. The VQ scan had a low probability, and we involved pulmonary, for which the patient was supposed to follow up the pulmonary hypertension clinic. Hematology also wanted to evaluate her for connective tissue disease. Her CBC with diff showed cystocytes positive, +1. They thought was secondary to her hepatic sequestration. She had a plasma score of 5 with intermediate risk for Adams 13 deficiency. Again, she was scheduled to follow up with hematology in an outpatient setting. So on the day of discharge, her bilirubin had come down to 3.9. Her AST, ALT were all trending down. Hemoglobin was up to 8.2, close to her baseline. She was discharged home on prednisone, 60 milligrams QAM for 1 week, and then with instruction to titrate down to 40. She was also to be seen in hematology, sickle cell, her primary care, GI, and pulmonary. But she only kept the appointment with her sickle cell providers, and that was back in May. So she came on May the 4th, came in, she had discontinued her prednisone without anyone's knowledge, to stop taking it. She had this weird feeling of pain in her chest. She was dizzy on exertion, and she had pain now involving her right hip. She was tachycardic. Her blood pressure had dropped below her baseline. Her tolerability had gone back up to 11.5. Her liver enzymes had also trended back up. Hemoglobin is now down to 5.3 after being discharged with hemoglobin of 8.2. The DAT remained positive, and again, no pulmonary follow-up, nor with hematology. And again, she was admitted. We did consult hematology, heme pathology, pulmonary, GI. She was diagnosed with AVN involving the right hip, and between being discharged from the hospital and coming back in for this clinic visit, for which she was directly admitted, she now has sickle retinopathy that was detected in the outpatient setting. The hospital course for her May hospital admission, she was diagnosed with hepatic sequestration, worsening and symptomatic anemia, autoimmune hemolytic anemia, and sickle cell pain crisis, treated with IV fluids, pain meds, and simple transfusion, as well as prednisone. And again, discharged home with prednisone with a titrating dose. So where are we now? She was seen again in clinic on February the 8th. During that period of time between May and February, she had 3 hospital admissions at an outside facility. Her DAT was now negative. She is on Oxbryta, 1,000 milligrams POQ day, and we reduced her dose because of her elevated LFTs, with plans to increase her to 1,500 milligrams POQ day. At her last clinic visit, her hemoglobin is now 10.6, her hematocrit is 30.5, her total bilirubin is now down to 1.5. ALT, AST have all trended down, and her ferritin remains elevated at 6,000. Hydroxyurea and J-nu had not been resumed, pending her ophthalmology and audiogram. During this period of time, she was also diagnosed with a PE at the outside facility, was now on Eliquis 5 milligrams twice a day. She now has AVN and sickle retinopathy. And of note, her AVN is being staged at a FECOG stage 2. Now, she's been compliant this time. She's been seen by her sickle cell provider. She's been followed by hematology, pulmonary, GI, and ophthalmology with an audiogram that's pending. And so our concerns now with this patient is that, she will resume hydroxyurea now that her LFTs have trended down as an adjunct to her Oxbryta, given her transfusion history. Should we go ahead and proceed with increasing her Oxbryta to 1,500 milligrams POQ day? Other concerns are, should we resume her J-nu in the presence of sickle retinopathy, and if so, what dose? Will we start at 14 mg per kg per day and titrate up, or start at 17 mg per kg per day? In terms of pain management, she's currently on oxycodone, 15 milligrams POQ 6 hours PRN. And so given that she has AVN, will we now consider Cymbalta as an adjunct to her oxycodone? Or will we consider Adapvio infusion, given the fact that she drives 40 miles one way, a total of 80 miles round trip? Transfusions moving forward, given her history of acute chest and autoimmune hemolytic anemia, is not going to be easy with multiple antibodies. And then again, transportation and lack of family support Again, she had a stroke as a child, and in my opinion, cognitively, her ability in terms of critical thinking is somewhat poor in terms of also her judgment. And so those are our concerns moving forward in trying to provide comprehensive care for this patient.
That is definitely quite a case. I'll start with a couple of things. I guess I would never hold Jade New for sickle retinopathy. The issues in Jade New in the eye is not retinopathy, so that's not a reason to hold it. But I'm going back. I'm not sure why you started her on prednisone in the first place.
So we did consult hematology with a positive DAT and a warm circulating antibody. It was recommended that we go ahead and place her on prednisone for that reason alone.
So something to think about is that we see a lot of patients that have warm autos that are not in an active autoimmune hemolytic crisis. Her Billy wasn't that high. Her hemoglobin was 6 when you admitted her. And I would say that's unless somebody has an LDA, I'll do anything to avoid prednisone because it's going to cause increased pain, increased problems, and more AVN. So I think that was probably premature, and probably someone who isn't, maybe, I don't know, that may have been an issue. But we usually would use IVIG first line in the case of sickle cell, specifically because of the detriment of prednisone in these individuals. So I was kind of surprised to see that. I don't know if other people have thoughts.
Yeah, I have a follow-up question on that. You mentioned that she went home on steroids after the second admission, but didn't say what happened to the steroids. Was it tapered off or what happened? That information was missing. And second question is, in the first admission, when you had the elevated LFTs, I didn't see any infectious disease workup.
So first question, we did do a tapering dose with her prednisone when she went home from the hospital, for which she did follow those instructions the second time around, and we were able to actually taper her off her steroids. In terms of infectious disease workup, I did not see where ID was consulted. She was and did indeed remain afebrile throughout the course of the hospital admission. And I did not see where blood cultures were done. So no, she was not worked up in terms of infectious disease from what I
was
can
thinking more in terms of like viral, like Ardie adenovirus with the ferritin skyrocketing from 1,000 something to 5,000. You see that adenovirus, for example. So some of those things I would have considered at the time of initial evaluation for this patient. As far as autoimmune hemolytic anemia and sickle cell, I don't have much experience in that one because we rarely see that. But in general, for autoimmune, whenever, especially in an adult, I'm sure the likelihood of chronicity is maybe more than pediatrics. So I would probably, IVIG, at least in pediatric garden variety autoimmune hemolytic anemia, doesn't work very well. As steroids do better. But we also start steroid sparing agents early on, like MMF or something early on. So we want to get them off steroids quickly. But in this situation, I don't know, like I leave it up to others with experience with adults, how they would have managed. But
We see it all the time.
Huh?
And Dr. Rowland, we see warm autos all the time. But they're rarely symptomatic. What were you going to say, Dr. Rowland? She had raised her hand, but she says for the warm auto is why the prednisone was started. I knew that's why it was started. It's just not, the question is whether it was truly a symptomatic warm auto. People with sickle cell disease can, oh, she says she can't unmute. Let me see if I can unmute you. People with sickle cell disease or anybody getting a lot of transfusions can look like they have a warm auto, but it's really an allo. And so it's not always requiring that treatment. All right, I'm trying to.
There we go.
There you go. Yeah, I unmuted you.
Thank you. I was going to say on the pediatric side, we actually see it quite often, especially during the winter season. We'll get kids that come in with viruses and they have a warm autoantibody, and the time of year is coming off the tail end of the winter season. So I'm sure it may have been related to something infectious. We do from time to time start our patients on steroids if they have pretty symptomatic autoimmune hemolytic anemia from sickle cell disease. You know, the pro and con of the IVIG, which you can use that too, is IVIG can also exacerbate hemolysis, right? Because it's just kind of a mixed bag of immunoglobulins and you're not really sure. So we actually have had patients that have had some exacerbation of their hemolysis with IVIG. So, I mean, I don't necessarily, I mean, I guess it's, you know, dealer's choice with whichever you decide to use, but at least at Children's, we lean heavily on steroids for patients who are symptomatic.
For delayed hemolytic reactions, at least in the transfusion guidelines from ASH, they highly recommend IVIG. Again, it's one of the lower, we don't have great data, but I would say that we use it all the time. And I haven't seen exacerbation of steroids, I mean, of hemolysis. It looks like Ophelia was saying in children, she's using prednisone too. But we have not seen it. I mean, we use it all the time. It's interesting because I think it's the adult world versus peds world. We would all rather use IVIG any day than prednisone, just because we see the huge exacerbations of pain.
So another angle in this case, can we discuss? I was curious about using prostacyclin analogs for pulmonary hypertension and why ambrisentan or bosentan or sildenafil or tadalafil were not used.
Hold on, that's a different question. Let's finish what you wanted to ask.
Okay.
And I think we would want a pulmonary hypertension expert on, but I was hoping, I'm sure you know that the recommendations are that you never diagnose pulmonary hypertension in sickle cell during admission. And so definitely want to go back and, I mean, I've seen it completely misdiagnosed. You get somebody out of the hospital and they're fine. So I'd be wary of that.
And she has followed up twice. They did do the 6-minute walk. They repeated the echo. And I'm not a pulmonologist, definitely not a pulmonologist. And so they have been following up with that. And she does have an appointment to see them on the 15th of April for additional follow-up. So I'm very happy to see that despite having to drive 80 miles each time she comes for a visit, and we've tried to kind of coordinate all of her appointments on the same day, if possible, to try to help get her here. To be more comprehensive in her management of care.
Pat Adams-Grays, nice to see you, by the way.
Oh, good to see you as well. Well, it's nice out here in retirement. I get to pick and choose what I'm going to do. But anyway, I have a question. Well, I have two. One is, did she have a right heart cath to document her? And I missed that because I was I'm not savvy and I had time getting on. So what were the pressures?
So she did have a right heart cath done. And basically based on the right heart, she had moderate elevated PA mean pressure, a normal wedge pressure with suggested pulmonary arterial hypertension.
Okay, so that's that question. So it's well documented. Now let's get back to the liver. I have a question. Sickle hepatopathy, is it really sequestration crisis, which triggered the drop in the hematocrit with a positive DAT that made you make the decision, or you guys make a decision about steroids and or was it the real sickle hepatopathy with occlusive canaliculi? Do you know?
Homeostasis is what you're asking about.
Is there any way to delineate the hepatopathy? Because it all works together, and the ferritin could be an acute phase reactant. I'm not even worried about the ferritin, but the bilirubin was the peak. The peak bilirubin was not massive, was it?
It's at 11.
That's sort of to me. Yeah, that's just to me hepatic sequestration, which can be observed in adults. Now, you know, we don't do anything with that except observe. And if the hematocrit goes way, way down, then we just give a unit. But this woman had the positive DAT, which was IgG, and that is concerning. So the blood banker that saw the pathologist, did they, it seems like they phenotyped.
Looked like it.
Yeah, they eluded it. So what, review, what was the antibody? I mean, you said autoimmune,
Mhm.
warm antibody, but if I looked right at the slide, they actually delineated the antibody, right?
And so
I
I
don't
have
think-
Dr. Baruka on to actually address that question that you have. And then my thought process was hepatic sequestration. But again, we bought in because again, 11.3, I wasn't too concerned with that. But again, being
Did-
not a hematologist, we did consult hematology and we consulted heme pathology as well as GI. And so they came back with the question of hepatic sequestration versus sickle cell hepatopathy versus iron overload versus sickle cell pain crisis, and basically signed off.
Yeah, it's a non-specific panagglutinin. It's just a warm auto. They
Well, it
didn't-
says here, yeah, it says here though that it was anti-Big C.
No, that's her other
What's
antibody.
that? Oh.
It's not the cause of her warm.
Okay.
I put her transfusion medicine report up there to give more information in terms of her transfusion history moving forward in terms of transfusion, working with a primary care doctor who we have reached out to on multiple occasions to please contact us before you transfuse this patient for a hemoglobin of 6, hemoglobin of 7.
We could talk about that all day for sure.
Yeah, we've
For
had
sure.
several phone calls and we've tried to talk with them, please call us. And then
So-
we've asked her to come to Mobile, but it's hard to come to Mobile when you're driving 40 miles and you don't have transportation.
I'm gonna move us along. We could really talk about that, I think, forever. And I do want to give our didactic speaker a chance to talk. I will say this is certainly someone who needs red cell genotyping, not just phenotyping. So
Yes.
that would really help you determine what to give them in the future. But I will also tell you that we see lots of warm autos that are not that are sort of not a concern in our adults due to this. They're kind of pretend autos. That's the best way I understand it. But regardless, I think it's a great case. And the other thing I learned, at least, and I don't know if this helps her or you, but I've never been able to get doctors to stop transfusing patients, but I've been able to get patients to tell doctors, no, I won't take the blood unless I hear from my doctor. So I don't know if that helps. I learned that from Pat, I think.
So
All right.
I know we're trying to cut it short, but Dr. Baruka, the pain pathologist, if we can unmute him for just a second. He was trying to answer Pat's question regarding the red blood cell genotyping versus phenotyping. Can we unmute him for just one second to allow him to talk?
Yeah, hi,
He's on-
this is Dr. Baroka. Can you hear me?
Yeah.
Yeah, so basically, this is a case that the blood bank received before I started in July, and I reviewed the case. And I agree with you, the autoantibody is showing a pan-agglutination, and it had a positive autocontrol, and the eluate was positive. And we usually here, we do not have the panels to do the absorption test, so we send it to the American Red Cross who did the autoabsorption for us, and they were able to identify the alloantibodies, which is the anti-Big C, Duffy A, and the JSA in their case. In addition to the warm auto, and that is present, and the warm auto, whenever we cross-match a unit, sometimes it gives us troubles, but that doesn't mean that it is going to be reactive. It just like doesn't cross-match with you, and then we usually we used to do in Mayo and Cleveland that we do an exceptional release for these units saying this is the warm auto and we are good to go. So the warm auto itself, if you don't do more investigation and clinical dig into see if it is reacting or not, usually the blood bank testing will pick it up, but it won't be able to tell you the clinical significance of it. It's just a nuisance for us, and whenever we are detecting the alloantibody. Now, the anti-Big C can be also one of the antibodies that is a true alloantibody, and the warm might mimic the anti-Big C, and that is a very common thing that the warm auto do, especially whenever we have the RH. And as long as you do not have an unusual antigen to which the auto is trying to mimic, it is not expected to hemolyze the patient. But these are like very, like they are usually like the testing is very hard because it is a serological test that is being done. And doing a phenotype and trying to get allele matched unit might be able to help us, but with the national shortage right now, we are having a lot of difficulties finding compatible units all the time. So basically, that's our input from transfusion medicine into the case. And the units that are given to the patient were negative for the antibodies. Also, we honored the K at that time and the RH in her case. And also, we are going now with the ASH guidelines that if we have a patient that is a high responder like her, we usually try to match the other antigens like the Duffy A, Duffy B, the S's, and also we extend to the JK, to the KIT group, as well as running a GATA1 mutation to see if we can drop the Duffy B from her units. So basically, right now, if whenever she's back, we will be more than happy to run all these genetic testing for her. And it is very hard to know, it is more like from the blood bank point of view, because if the worm is, if the serum or the titer inside the serum has a high amount of worm auto, it will always be a nuisance for us, and the unit will not cross match. So basically, that's always one thing that we keep in mind.
Thank you.
You're welcome.
All right. I want to just move us along real quick to get our didactic. Feel free to, it looks like the conversation is ongoing in the chat, which is totally great. And I think there's some questions in there for you, Dr. Baruka. All right, so let me get our introduction real quick for Dr. Hayes because it just closed on me. All right. Dr. Hayes is assistant professor within the Division of Child and Adolescent Psychiatry and Psychology at the University of Louisville School of Medicine. She is a psychologist for the HEMONC services at Norton Children's Hospital and Norton Children's Cancer Institute, with expertise in intervention and research related to psychosocial needs of pediatric hematology and oncology patients. She is also the co-PI for 2 studies, including 1 grant-funded research study related to pain management for youth with sickle cell disease, and 1 study focused on implementing standards of biopsychosocial screening in pediatric sickle cell to improve access to care. And Lauren, I do need to connect you to our national group who's also doing some consensus work on standardized biopsychosocial screening at a later time. But thank you for coming here to talk about Pica.
Okay, I think I'm unmuted. Yes. Can everyone hear me? Great. And I just dropped a link. I'm trying out a new technology. Bear with me, folks. If it doesn't work, that's okay. But I just dropped a link to just a 3-question survey that will pop up hopefully in the slideshow, just trying to get a kind of baseline assessment of where everyone is at with Pica. I know sometimes Pica is kind of put into a psychology box or a mental health, behavioral health box. So I just wanted to see where everyone was at. But I am planning on talking about Pica and sickle cell disease and discussing a multidisciplinary assessment and treatment recommendations. Oh, goodness. All right, I have no disclosures. Oh, fabulous, it's working. Okay, so as people, I have 2 responses. So if folks could quickly either use the QR code or the link in the server or in the chat, so I could kind of get where everyone's at with things. So these 3 questions are: I'm familiar with symptoms and diagnostic criteria for Pica. I feel comfortable identifying and diagnosing, and then I'm knowledgeable about evidence-based treatments. Okay. Great. So just out of a quick, 9 or so responses. Whoa, I love when technology works out. I see that people are feeling somewhat comfortable with symptoms and diagnostic criteria, identifying Pica, maybe less or so with the evidence-based treatment. So we'll talk a little bit about what this looks like from a multidisciplinary perspective. Oh, great. Okay. So just an overview of Pica. Pica is defined as a pattern of eating 1 or more non-food items on a consistent basis for at least a month. So some definitions use, I highlight eating there because some definitions use mouthing or eating. Really, true Pica is eating, so ingesting 1 or more non-food items. It is important to note if a child is mouthing at foods, because that can be kind of a precursor to actually ingesting foods, but for full criteria, it is eating. This falls, this pattern of eating falls within a developmentally atypical time, so older than 18 months of age. Even, up into 2, 3, I'm careful when I'm diagnosing, but after that cutoff point, there's clearly a pattern of eating that is not developmentally appropriate. It's also pica, to be diagnosed with it can be related to cultural or religious practices. So in some cultures, eating dirt is seen as therapeutic in some ways and is used to address like nutritional deficiencies or even been associated with pregnancy and things of that sort. So just making sure that it's not a religious or cultural practice that someone is engaging in. Some of the most common food items that we see in sickle cell include things like fabric and toilet paper, dirt, styrofoam, drywall, in fact. Starch is also common. All right, so lots of information on this one slide. I want to highlight pica in the general pediatric population, although we don't have exact estimates, ranges from 25 to 50%. So big range, high numbers, and that's just in general pediatric populations. When we think of pica, especially from a psychological lens, we think a lot of developmental delays, autism is what it's commonly lumped in with. But actually we see high rates of pica within youth with sickle cell disease. So a couple different studies I've cited here have different findings. One study found that about 34% of a sample of almost 400 children were found to have pica, and those with greater disease severity, so SS disease, had a higher prevalence of 36%. And then another study found that almost 52% of children had dysfunctional eating patterns, which included pica. So that gets a little funny. So I typically, like to think that at least 30 to 40% of kids with sickle cell disease have at some point in their life had pica. What is known about, because I know there's some adult folks on the call, what is known about adults with sickle cell disease and pica is far, far less. So if you're interested in research and you'd like have an interest in pica, this would be a great place to start. I did find one study back from 2005, small sample of less than 100 adults. 76 reported having pica at some time during their life, most often in childhood, but only 16% endorsed current pica symptoms. So of 75 or 76%, 16 were currently experiencing pica as an adult. So much lower percentage than what we see in childhood, but it's also still a notable amount. And like I said, pica is typically thought of as kind of a childhood phenomenon, but it does obviously occur within adults as well. So thinking about pica from a multidisciplinary lens, it's not exactly the delineation between pica and sickle cell disease is not very super clear. So there's a lot of hypotheses that have been thrown around. And to be honest, I really like this Rodriguez article that talks about the biopsychosocial kind of perspective on pica and sickle cell disease, considering the different buckets. So biological, psychological, and social. So things like nutritional deficiencies and disease severity have been linked, but not in isolation. So psychologically, high stress and limited coping skills, comorbid mental health diagnoses, learning delays or difficulties, neurodevelopmental disorders, those can all be put you at higher risk for pica. And then when we look at like the family environment, family stress, a family history of pica, and then food insecurity, those can all be linked to higher prevalence of pica. So really is why we kind of recommend, and what this article recommends, this multidisciplinary approach, because it's not just one etiology that is linked to pica and sickle cell disease. So we have to approach it from a multidisciplinary lens. So I'm sure a lot of you all are maybe familiar or can guess as to why pica is not good. This is a big piece of education that I do with families, just the dangers of pica, infection, gastrointestinal issues, lead poisoning, tooth damage and tooth decay, and then ingestions of pathogens and parasites. I've had several kiddos, let's see, one who will eat dirt, and will eat dirt that he finds in his backyard where his dogs go to the bathroom. And so, you know, that you can only imagine, or maybe we shouldn't imagine kind of what could be involved in that, and the ingestions of parasites or pathogens. There's also kiddos that I've worked with who will pick paint off of the walls or off of window seals, and then have lead poisoning. And so there's lots of dangers involved with this. So we know it's bad and we know it occurs often. What do we do? And it's quite simple. Is kind of implementing a screening process. Well, in theory, it's quite simple, right? What a research study, Reed, Knight et al. In 2015 used this one question to screen. The implementation and the consistency behind it, and then connecting families to resources and treatment, is kind of where the more difficult part comes in. But this question, does your child eat anything that is not food, is a very simple question to screen for pica. So that's something that I use in our clinic all the time to assess for pica, kind of in I throw it in, I assess for all kinds of different things. And that's just one question that I ask that can get to the bottom of if there's pica. And it's really interesting, kind of my comment, stigma associated with pica. For those of you who maybe have asked patients or assessed for this before, you maybe know what I'm referring to, but I will ask this question, and pretty much before the patient answers or verbalizes anything, I can tell based on their reaction if that's something that they engage in or have done before. So often I'll get people like, what are you talking about? That's crazy. No, heck no, we don't do that. And kind of a curiosity, but just you really kind of thrown off that I'm even asking. But on the flip side, I see patients feel really, maybe look down, feel really embarrassed or shameful, maybe some like nervous giggling. And so that is where the stigma comes in. This is kind of a sensitive topic, an embarrassing thing that people don't always want to disclose. And so when you ask this question and maybe you get a response of really defensiveness or embarrassment or shame, I think it's really important that we normalize that pica is common with kiddos with sickle cell and adults with sickle cell disease. And this is why I asked this question. And sometimes even with patients who I have a good rapport with, I say, now I'm going to ask you something kind of crazy. You might think I'm crazy, but I asked this for a reason. So just prefacing and kind of addressing that it's uncomfortable, but there's a reason we're asking about it because it's common. Okay, so they screen yes. So yes, they tell you they do. Okay, so some follow-up questions you'll want to ask is what is the item or items that you're consuming? When was the first time you ate drywall? How long has it been going on? Did it start at 6 and the age of 6 and never stop, and now you're 13? Was it at 6 and then you haven't done it for a couple years? So really getting a good timeline. How often is this occurring? Is the actual behavior occurring? Is it every day? Is it once a month? Are there certain times when the behavior occurs more often? And then of course, have there ever been any consequences of the eating behavior? So have you ever been hospitalized or had a bowel obstruction? Or had, to get treatment for lead poisoning. So making sure just kind of getting a full picture of the pica behavior itself. Some other things, and I'm the psychologist, so I don't know, I can't fully explain these labs, but some of the literature suggests that lab results can be helpful data points when you're assessing for pica. So we know that disease markers have been linked to an increased risk for pica. So hemoglobin, retic, so lower hemoglobin has been found in children with pica and sickle cell disease, and then a higher retic. And so you can look at those. And again, these are just one piece of the puzzle. Ferritin levels and zinc levels, because iron deficiencies and zinc deficiencies have been linked to pica. And actually there's been studies that zinc supplementation has been linked to pica resolution. And then last, you'll look at blood levels in order to ensure that there was no lead poisoning or lead toxicity. And if so, that would obviously need to be addressed and treated. We doing on time here. Okay. So because we're conceptualizing pica as a multifaceted, kind of multifactorial problem, we also want to address it in a multidisciplinary manner. So there's lots of different disciplines that should be involved in the treatment of pica. Medical, obviously, so addressing any dietary imbalances, taking nutritional supplements or prescribing nutritional supplements to address some of those deficiencies in iron and zinc. And then treating any, if there's any psychiatric medication that's being prescribed for comorbid mental health diagnoses, that should also, that falls in kind of the medical category, making sure disease is well managed. Behaviorally and psychologically, there's lots of different behavioral interventions that a mental health professional can implement with children or with adults as well. The first would be to do kind of a full diagnostic evaluation to ensure. We see a lot of like obsessive compulsive disorder, more anxiety disorders that are comorbid with pica. And so you really want to make sure those mental health diagnoses are being treated first. And then, I started doing treatment with a patient who was engaging in pica, a 16-year-old, and he ended up having, once I got him in to do a full diagnostic evaluation, having more severe depressive disorder that warranted substantial treatment before we could address the pica. So sometimes pica can be kind of your clue into maybe there's more mental health concerns going on. So referral to a good mental health provider would be really important. And with that, developing coping skills to manage stress and emotions. Pica can sometimes be, it can maybe first develop as the result of a nutritional deficiency, but then it turns into a habit, and it's then turned into a coping skill that's used to cope with stressors, maybe when there is no foundational kind of coping skills or ability to manage stress. So that's kind of where we see how years and years down the road, labs may all be within normal limits, but it's still a behavior that kiddos are engaging in as a way to deal with stress. So again, this kind of speaks to the multifaceted nature of pica. There's a lot behaviorally that we can do in really brief interventions for just pure run-of-the-mill pica. So we see, and I see Dr. Raj raised his hand. Did you want to say something? Oh, you're muted.
So I can say after the talk, no worries. You finish your talk.
I'm sorry, what was that?
I will ask my question after you finish your presentation.
Oh, okay. All right. Yeah, so like I said, I'm watching time as well. Behaviorally, there's a lot we can do in really brief interventions. The first and foremost is psychoeducation. So giving families just the brief rundown of what pica is, what to monitor for, normalize it. So many times I have families say, oh my gosh, I never knew that's why they did that. Or this is making so much more sense. And just opening up the conversation. I'm talking about the dangers of pica, why we need to address it. But then behaviorally, if patients and families are ready, offering, coaching parents through giving praise and affection and developing reward systems for pica incompatible behaviors. So chewing gum or humming. So offering that as an alternative to the habit or the, eating whatever substance it is. Reduce or limit access to pica, particularly that's really for parents of children with limited insight or who are younger. So making sure that they're limiting access to the preferred item, pica item, and offer alternatives such as, enriching developmentally enriching toys and activities, parental interaction. And then last, offering a substitute. Sometimes patients particularly gravitate towards certain food or non-food items because of textural issue or textural or taste or appearance. And so offering them food items that are similar and characteristic to the non-food items. So offering a rice cake instead of a styrofoam. So those are just some quick examples of behavioral strategies. And like I said, clinical implications, just really being aware as a medical team. Most important takeaways that I'd like you all to walk away from this with are just being aware as a sickle cell provider that pica is common not only in pediatrics but also in adult patients with sickle cell disease. We really should be routinely screening these patients for pica. The complications that can result from pica are just too dangerous, and it's really simple fixes, the treatments that we can offer. So it's an easy fix with grave consequences if it's not addressed. So routinely screen and then provide evidence-based treatment or referrals. So find someone in your community. If you have a behavioral health provider in clinic, make sure they're familiar with pica, have pica resources available to provide to families. And if you have no behavioral health provider in clinic, finding someone in your community you can refer people to would be really important. I think that's it. So questions?
Hey, Lauren, awesome presentation. Thank you for sharing your thoughts. I just wanted to bring this for discussion. As far as the cause of pica and sickle cell disease and comparing it and contrasting with pica due to iron deficiency or zinc deficiency you see in children other than sickle cell disease, I personally feel that this is more of a symptom of anemia, which patients, can develop mild to moderate cognitive impairment as a consequence of anemia, chronic anemia. And that could be giving them some intellectual disability and also having autistic spectrum type behaviors. So the reason I'm saying that the pica that sets in sickle cell disease is harder to treat compared to that with iron deficiency or other things. You correct those deficiencies, they tend to respond better. But with sickle cell disease, it may be harder and to treat. And so we may have already caused significant damage from the chronic anemia that has gone on for many years, So that's my thought. I don't know what others feel.
I have a question. As you know, pica is very common in pregnancy. Is there any literature or papers out there that give you some kind of signal or hint as to the cause during pregnancy that could be extrapolated over to sickle cell? Because I know a lot of pica folk have ice picas when they're anemic. I had a patient that had the toilet paper and she would bring it with her, and she had a Bezor and finally shamefully said that she had never told anybody. She was in her upper 30s by then. And she actually had to have a mechanical, they didn't have to cut, but they had to, ream it out. And she was a mild sickle cell case. She was SC. And so I've seen a lot of pica, but is there any correlates with the pregnant pica issue?
I have heard that. Yeah, I mean, I'm a pediatric psychologist, so I can't speak too much to pregnancy. I don't see that a lot in my patients, but I do believe there is a link. I just couldn't speak to it.
Also, Lauren, I asked another question in the chat, whether you make a distinction between pica and non-suicidal self-injurious behavior, such as swallowing batteries or needles, etc. Are they sort of related, or do you think you make a distinction between the two?
That's a good question. I think there's definitely a distinction. So if there's an intention to harm oneself, then that's self-injurious behaviors. Whereas pica is purely, more driven by kind of a craving or a desire, for the food or the non-food item. It is very different kind of motivations. And that is a good point to parse apart.
So there is a fair amount of pica in pregnancy, but I think it's often, at least, I see a biased sample of pregnant people, but there is that association with iron deficiency, which is clearly more common in pregnancy. And we do see more iron deficiency in our patients with SC and S beta plus thalassemia that are less likely to be transfused. So that could be driving it. Can you comment on people that eat excessive ice, that have ice craving?
That's something that I've always heard connected to iron deficiency. And that's something that that is an interesting conundrum I've found myself in, that it's sometimes not included in the non-food item that screener question will ask about. But it can often be, I think, a precursor to other non-food items that someone might eat. So if someone says they eat ice chips, then that definitely makes my ears perk up. I do a little bit more of a thorough assessment, ask a little more questions.
In my clinical experience in adults is that it's about half of adult women with iron deficiency that I see have cryophagia or really eat the ice chips or other forms of ice. Not nearly as common in men for reasons I can't explain.
Well, it's 5 o'clock, so I just want to thank both of our speakers today. It was a fantastic case and a great presentation, and really, really important topics. And thank everybody for your great participation. I am going to leave you with the funny story of when I learned about Pica when I was in med school, and I still remember it. They said, eats non-nutritious foods or non-nutritious items. And I was like, well, great, then I have whatever this is. And then they started talking about styrofoam and flour. So whenever I hear Pica, I think about all the non-nutritious food I ate in medical school. With that, I will leave you that I do not have Pica, but I had a patient who walked around the hospital with a bag of flour and a spoon. So thanks, everybody. See you in 2 weeks.
Bye.